Beautiful. Yes, we are live. We are live. Welcome to MedCognito NCLEX. It's a joy to join you every Thursday to help you gain some clarity on some must-know topics for the NCLEX. And I am your wonderful tutor, Dr. Julia, joining you right from Ontario, Canada. Today, we're going to break prioritization into pieces. So stay right here. Invite all your friends to come in and let's dive right into it. So let's go. I'm going to give you some prioritization rules. Do well to keep these rules throughout your practice because it's so important. Prioritization helps us to know what is really needed and what to do per time to save our patients. So let's dive right into it. So let's look at the first rule. Rule number one, the ABC, airway, breathing, and circulation. And it's important that you hold on to ABC because it will help you know which client to prioritize. If you have a client with airway obstruction, a client in respiratory distress, you have a client bleeding, these should come before anything else, okay? And take this tip that in any question you have a patient who cannot breathe, then prioritize that client. If a patient cannot breathe, then nothing else matters. What I'm going to eat does not matter if I cannot breathe, okay? So always prioritize airway. Let's look at the second one, Maslow's hierarchy of needs. When you look at the Maslow's hierarchy of needs, we have the needs arranged in order of priority. So always look out for the physiological needs first. The need for air, food, water, elimination. Look out for that first in your prioritization questions. That will come before your client who needs some safety or the client has emotional needs and your client wants you to help him or her get reconnected with the family, but your client has to breathe, has an airway problem. Your client is complaining, I want to get connected to my family. That is an emotional need, but we have to solve your physiological need first. So that comes before safety and then every other thing. Example, I'm in pain, but I need oxygen. What are you going to prioritize? Prioritize the oxygen before you sort out my pain. So the trick here is that, yes, when you see pain, you may get confused. Oh, am I being insensitive that my client is in pain and I'm not minding him or her? But pain is not priority over airway or circulation. Always take note of that, okay? Then let's look at the third one, actual versus potential. So you have to treat actual problems first before you address like some risk. Let's say you have a client and the client has chest pain. This is an actual problem. What if your client has issues with turning? So we are suspecting that, oh, okay, we have to turn this client because he or she is prone to some skin breakdown and we have some bed sores. That is a potential. It can happen, but we have to take care of the actual problem now before we take care of what we are anticipating. Okay, so take note of that in your prioritization. And then acute versus chronic. So if you have a list of cases, look out for what is acute, what is new onset, or what makes your client unstable. That comes before the chronic patient or the stable patient. If a client comes and this is an old person with a known COPD, is a chronic case, you have to do well to bring the acute issues first before we deal with the chronic. So example, you have new confusion in a stroke patient, that is acute. We have long-standing arthritis, that is chronic. Then you have these two clients, you have to choose the new confusion in a stroke patient first. Let's look at this unexpected versus expected. This one, it confuses a lot of students because they feel that I have to address this challenge first, but it is expected. when the client has that condition. But if you have an issue which is not expected, you have to prioritize what is unexpected before you take care of the expected. Let's make it easier. You have a post-op patient with sudden onset of shortness of breath. And then this client has gone through surgery. There's an incision. So there will surely be pain. So you get the client is breathless, and the client says, I'm in pain. I'm having issues. I'm having a lot of pain at the incision site. But I'm also trying to get in air. Sometimes you may get confused because you feel you have to attend to the pain first, but solve the breathing problem first. Unstable versus stable. When the client is unstable, you see words, keywords like unstable in your question, prioritize that. Signs of what are some of the signs that this client is unstable? They tell you that the vital signs have changed and they've worsened. Not that they've changed for the better, it has worsened. There is a new one, a new onset of chest pain. Low oxygen saturation, the mental status has changed. Watch out for these words. And then the stable client can wait. And let's look at the 7th rule. Systemic versus localized. So there's a challenge, and if it's affecting the whole body or it's just at a local site. Let's look at the sepsis with fever and tachycardia. It means that the sepsis is not gotten, the infection is not in the blood. That's what we call sepsis. It's systemic. And then client has maybe a localized lesion on the limb and he's reddened and you're thinking it's cellulitis. What will you have to handle first? You handle that client with sepsis before you come to cellulitis. We are not saying that the client with cellulitis is not important. No, this is about prioritization. Who is going to die first? Who will get the condition worsening so fast? Do well to remember this. Let's look at 8. Is it a trend or is it a one-time issue? So if in your question you have ongoing trends, that is more serious than an isolated value. You have a series of blood pressure recordings given to you for your client. And then you are also given one isolated reading. Let's say the blood pressure is really dropping, and then maybe they gave you some recording of maybe sugar, blood sugar or something. If you see that the blood pressure is steadily dropping, it is a trend, you have to pick that as a priority first before you pick that just once. Maybe the blood sugar has always been good and then one low recording, and you want to rather go and focus on that. Whilst on the vital list, you see that the blood pressure has been dropping steadily. Prioritize the trend, which is worsening, okay? Great. Are we good so far? Give me a thumbs up in the chat box. And let me be sure I'm not here alone. All right, great. So let's go in. So 9, infection control. So if we have life-threatening infection control safety, if we have life-threatening safety risk, like an old person who is at risk of a fall, we are seeing some indicators for suicide. The client is saying, I think I must end it all. I have changed my will or whatever. Like you get all those indicators in the question, which means that clients can kill themselves. Prioritize that, okay? Anything around fire or wandering, these are safety concerns and it should be on your top priority. If you have an infection in an immunocompromised patient, it is a priority. Always prioritize that. Great. So let's look at the last rule. Time-sensitive treatments. Some interventions like these, when you see it in questions, they cannot wait. A client needs thrombolytics. You cannot wait. So prioritize it. A client has severe hyperkalemia, and insulin helps with the shifting of potassium. It is a priority. A client, remember last week we had a client with sepsis and antibiotics, very important. A client with anaphylaxis and needs epinephrine. This is important, and always remember to look out for these, and it will guide you in your prioritization. So let's go into testing ourselves based on what we have studied so far. So I'm giving you an example before we dive into our questions. So let's look at this quick example. We have 3 patients before us. Always put yourself in the clinical scenario. Don't just look at it as a question, okay? It will guide you in taking the right option. I have a client on the ward. This client has asthma. I go check the oxygen saturation is 88%. Then I have another client, chronic pain. Maybe he's been on the ward for like a month or so, and is been back-to-back pain, and we always sorting out the pain, okay? So we also have another one. You've known this client, he's stable and now awaiting to be discharged. So we're going to do some teaching. You have to look out for, so ABC, before ABC comes first before chronic patient and even with teaching. So asthma, we have to choose this patient first. See the oxygen saturation. I have to attend to this client. And then, yes, the pain is 8/10. So I'm going to attend to that first before the client who is stable and awaiting discharge. Just have to do some teaching. That comes third. You should not be found teaching a client while someone has a low oxygen saturation, and you have to address it. You are not a safe nurse if you do this. So that's why NCLEX will test you on prioritization, because NCLEX wants to know that you are safe. Great. So get ready, get ready, get ready. Let's dive into some questions to make sure that we will be able to ace any question on prioritization for our NCLEX. Okay, so let's go. So taking some deep breath and put on your thinking cap, analyzing cues, everything. And let's dive into this. We have 3 patients before us. Patient 1 has acute ischemic stroke, and the blood pressure is 200/110 due to antihypertensive. Okay, and then patient 2, that client is due for antihypertensive. Yeah, I did not say that right. Due for antihypertensive. 2, post-stroke with right-sided weakness. And then client will say, I want my pain medications. I'm in pain. Why are you attending to me? Then patient 3, stroke 2 days ago, and now suddenly has slurred speech and then facial droop. So, which of these patients are you going to prioritize and why? So let's go. Patient 1, patient 2, patient 3. Drop it in the chat box. Drop it in the chat box. And why are you going to prioritize that patient? And remember, I told you to look out for some keywords. So look out for it. Acute over chronic, unstable versus stable, airway prioritization. So let's apply all the rules that will work in this patient, in this question. Let's go. Let's go, let's go, let's go. Let's go. Anyone. Okay, I have patient 3 for peace. So you want to attend to stroke 2 days ago, now has slurred speech and facial droop. Okay. So why will you prioritize patient 3? You can add your reason. Okay, Darling chose 1 because Darling thinks that this client has acute ischemic stroke. The BP is 200/110 and it's due for antihypertensive. Look out for the keywords. Okay, let me help you out. Yeah, please, you got it. It's patient 3, stroke 2 days ago. Now, suddenly, so the keyword here, suddenly, and is a new onset. Now, suddenly has slurred speech and facial droop. So what is happening? That suddenly, the client is having these new symptoms. Yes, we know that this client has acute ischemic stroke and has high blood pressure and is due for the antihypertensive. It doesn't mean that this client is not important. This client is important. This is post-stroke, right-sided weakness and needs the pain medications. This one, 2 days ago of stroke, so it's still acute, and now suddenly has 48 hours, then now suddenly, that's why we choose patient 3 over patient 1. So if you are supposed to arrange it, it will be patient 3 first, patient 1 first, and then patient 2. So when we are prioritizing, we are not saying that patient 1 does not need help. No, but we are saying that we will choose this first before the other. So new neurological deficit increases indicates a possible stroke extension. So maybe it's ischemic stroke, and what if there's a bleed? Maybe it becomes hemorrhagic. We have to take immediate action. So anytime you see a new or unexpected finding, do well to go for that, okay? And then ABC will come before attending to pain and then the hypertension. Great, well done. Let's test ourselves again with this. You are in the ED and you have 4 patients. The first one is 25 years, has asthma, there is mild wheezing, and client is talking in full sentences. So this is there for a reason, talking in full sentences. Because you know that when they really get breathless and you're catching, they would want to catch their breath, they're not able to complete sentences. Yes. So 60-year-old with crushing chest pain and has diaphoresis, that is patient B. 45-year-old with vomiting and diarrhea, signs of mild dehydration, that is patient C. 80-year-old with hip fracture, stable vitals, pain is 9/10. This is D. So we are going to arrange these 3 patients from highest to lowest priority. So let's start arranging, whether it's A, B, C, D, whether it's B, C, A, B, let's arrange it. So who will you see first? Who is dying right now? Who is dying right now? Let's go. Let's arrange it. Take it that you are right on the ward and you have these lines before you. Who's going to die first? Apply all the rules. Acute versus chronic, stable versus unstable, ABC, Maslow's hierarchy of needs. Apply everything. All right. So let's see. This is this is the correct order. We have B, A, D, and C. So B was the client with crushing chest pain. Crushing chest pain with diaphoresis is suggestive of an imminent myocardial infarction. Crushing chest pain in a 60-year-old with diaphoresis. This is super important. Then A, you have the asthma with mild, we take airway, but see that client has mild wheezing and talking in full sentences. Okay, so although client has asthma, there is mild wheezing, and client is talking in full sentence. So after we have engaged MI, which is an acute, we come to this. The client is chronically known like to have asthma yet, but there's been some wheezing and we have to attend to it. But it's not that bad. Client can speak and can complete sentences. Okay, so yes, we're going to engage airway, but that one will be second. Then we go to D, 80-year-old with hip fracture. When you see stable, the client is good, but the pain is 9/10. 9/10. So we take D first. And then you may be wondering, what is it that we did not attend to this client early? Client has some vomiting, yes, has some diarrhea, and the signs of dehydration, they are mild. So this client is not going to pop any soon. It's mild signs of dehydration, and even with treating mild dehydration, we even encourage oral. We might not even go set any IV to give infusion. So that's why this is the correct order. The chest pain, we want to rule out MI. Clients can die so fast. Asthma, wheezing has started. There's a risk of asthma exacerbation and the risk of airway compromise. Client who has a hip fracture, yes, it's stable, but 9/10 is kind of severe pain. And then vomiting. This client, yes, is stable. And the risk of dehydration in this client was mild. Okay. So please, when you see chest pain, assess it very well. See how acute that is, and then pick it. Then the airway risk for the client with asthma, then manage the pain, and then the stable dehydration. Are we good? If you are good, let me know. Yes, yes, yes. Or there's any confusion, let me know. Let me know. We're going this one. This, I expect you all to get it. Okay, great. Thanks for the feedback, please. Let's look at this pediatric question. This should be very easy. We have a nurse taking care of 4 children who will require immediate attention. Always remember the rules, okay? So 6-year-old, epiglottitis, sitting upright and drooling. 10-year-old with appendicitis, and the pain is 7/10. 2-year-old with fever, 38.4, and drinking fluids very well. 12-year-old with sickle cell crisis, asking for pain medication. I mean, pain, give me medication. You know, those kids who will be crying. So, who will you prioritize? The one shouting on top of their voice at that corner of the ward, or you're going to really assess, put your thinking cap on, and see who's going to die soon. So let's go. This should be an easy one. This should be an easy one. Apply all the rules: airway, breathing, circulation, acute versus chronic, stable versus unstable. Who's gonna die soon? So with this, we are choosing one. This one, is said, which of these require? So we are not arranging it from highest to lowest priority. We are choosing one of them to C2 right now. So that means that you chose, and let's see. Yeah, so please choose C. Okay. There is one client here who is having issues. I don't know why you're not seeing that client. B for Miley. Appendicitis and pain is 7/10. There's one client screaming at you. That client, when you see that case, you got to run. Yes, darling, got it. Great job, great job, great job, great job, great job. It is A. It is A. It is A. Epiglottitis, sitting upright and drooling. This is urgent, urgent, urgent. You have to rush for intubation because this client can obstruct very soon. Please, please, epiglottitis, airway emergency, there's a risk of sudden obstruction. This does not mean that this client does not need help. They all need help, but who requires immediate attention? Please, 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 airway, airway, airway. Even when you look at all the cases here, the only airway staff is epiglottitis, and we did not have any of the other rules, maybe the word acute or a sudden onset or a trend increasing like vitals or something. No, that's why we go for it. Okay, I hope we are all good. We are all good. Epiglottitis. Well done. Done. So let's look at this. I hope you are appreciating prioritization. So you are caring for post-op patients. So these are some of the questions you can meet. You have post-op cases and you're being asked who you're going to see first. So let's dive into it. A patient 12 hours post-op with temperature 38.5. B, a patient 2 hours post-op, 78/46 blood pressure, heart rate 130, that is high. C, a patient 24 hours post-op requesting assistance to ambulate. D, a patient 6 hours post-op reporting of nausea. So we're choosing one. Which of these are you going to run after? Which of these? Look at the number of hours post-op, look at their vitals, and anything about the client which will cause them to deteriorate. Let's go, let's go, let's go, let's go. This should be easy. This should be easy. Welcome, Adebikola. Good to have you. We are talking about prioritization for NCLEX. Prioritization questions, you will all meet them, trust me. So we have BBB, BBB, please choose B, mine choose B. Yeah, great. Well done, everybody. You were able to spot the hypotension. You were able to spot the tachycardia. You have a client has come back from surgery, just how many hours? 2 hours. And now blood pressure is dropping, heart rate is increasing. What if the client is bleeding, intra-abdominal bleeding? There's some bleeding. They did not secure some like cut vessels so well, hemostasis so well, and the client is in shock from bleeding. It's life-threatening. We have to act fast, okay? So well done, everybody. Let's look at this, another one. We have 4 patients. Who are we going to see first? Post-op patient, pain 9/10. Client had a knee replacement. B, COPD. Client, you know that the client has COPD. Oxygen saturation is now 82% and 2 liters on 2 liters, yeah, oxygen. And then drowsy, client is having difficulty to arouse. We are having difficulty to arouse this client. And then C, patient with pneumonia, temperature 39.2. D, patients awaiting discharge teaching for hypertension. Great. Let's go. Yeah, I think we call choose B. Darling, choose B. Well done. Well done. Yes, Mary chose B. Yes. So it looks like you are now getting the concept for prioritization. B, that client COPD and oxygen saturation is 82%. Likely CO2 narcosis and respiratory failure. So we have to watch out for the airway first and breathing first before we come attend to pain, fever, and then even clients teaching. Okay, well done. Let's see, do we have any question more? Okay, so we finished with the last question, but I want to do a quick recap. Hold on to these rules and keep answering more questions on prioritization so that no matter how the question is framed, you will be able to pick the right question, whether it's a case study, it's a bow tie, it's a select all that apply, whichever form the question would come. When you know the concept, you should not get confused. So let me make it simple for you. Remember the acronym and save acronym. Look out for unstable vitals in that question. Look out for that client who has come up with new symptoms. Look out for that client who has come with some sudden changes. Remember that client with stroke who has some sudden changes in the sensorium and facial palsy and all of that. So you look out for sudden changes and then look out for actual problems versus potential. You have that client who has difficulty breathing, likely this client is having respiratory depression. Maybe the client has been given maybe opioids, and then that same client has maybe has been lying at one position, and we are thinking that, oh, we have to be doing some turning because this client can get potential bed sores. Why are you rushing to go sort out the bed sore issue whilst you have not sorted out my main issue that can kill me? So yes, it's good you anticipated bed sores and we're going to do some turning and do all that. We have the pressure areas and all of that, but solve the actual problem first, prioritize that. And when you have a case and you see first post-op client, especially in less than 24 hours, do well to prioritize them because they have a lot of issues around that time. And then you have emergent conditions like MI, stroke, and then sepsis. Watch out for this, okay? And remember this, I'm leaving you with this as well. SOS. Anytime there's a sudden change, anytime there's some obvious distress in the client, you see signs of shock, watch out and do not miss it. Do not miss it. So let me take you to let me just run you through the rules. ABC rule 1, remember, airway. the breathing, circulation. Maslow's hierarchy of needs. Solve my physiological needs before maybe my emotional needs and all of that. So always apply the Maslow's hierarchy of needs when it is needed, okay? Actual problem versus potential problem. Solve my chest pain before thinking about me being at risk of getting some bed sores. That is a potential problem. Solve my acute or my new onset problem or issue that will make me unstable. Solve that first. So see that client who has new confusion before you go see that client who has a chronic arthritis. Expected finding. Post-op client has sudden shortness of breath. Post-op client says, I'm in pain. I'm having pain at my incision site. I have to address that the one who has issues with the breathing before I sort out the one with the expected pain at the incision site. That is expected. Unstable versus stable. If you see any markers of instability in your client, prioritize that. And how will you pick it up? Sudden change in the vital signs. New onset. There's a new onset of chest pain. Low oxygen saturation and mental status changes. Prioritize that. Stable patients, they can wait. Systemic versus localized. Solve the client with sepsis. Solve that first before you go sort out cellulitis on someone's foot. Okay? Prioritize that. But if they say the client has cellulitis and then they add some other keywords, options, that makes prioritizing the case with cellulitis first based on the rules. You just have to understand it and know how to apply it. Okay, you're not going to go by fast, like going to follow these strict rules, but apply all the rules to guide you. Trend versus one time. This client is having blood pressure dropping steadily, and it is very low now. And that another client has had good recordings of maybe blood sugar, and there is one low recording. We're going to prioritize the trend first before you see the other. And then in the area of infection control, you have a client who has been on chemotherapy and they said this client has neutropenia, all the white blood cells are down. That client will pick up infections so fast. Prioritize that client. So write it down. Before you sit for your exam, you should read everything about neutropenic precautions. Neutropenic precautions is a must know. If you have clients who have had neutropenia, their white blood cells are dropping, that client is very special and you must know all about them. How we're going to keep them on the ward. We do not even have to bring like fresh flowers and stuff to them because they can catch infections so quickly. So read about neutropenic precautions, okay? Yes. And then the last one, time-sensitive treatments. A client comes, they're expecting some clots, they need thrombolytics. It is urgent, prioritize it. Hyperkalemia, anything around potassium, look at it very well, okay? Then sepsis, then anaphylaxis, super, super important. So yes, we are done for today. How has class been? And as always, I say that keep practicing, keep building the muscle and prepare for what NCLEX will be testing you, the various areas you have to read. Go to the website. I shared some links with you inside of the group. Know what NCLEX expects of you so that anytime you are reading, you know what you are working towards. Do not just start reading when you do not know what NCLEX expects of you. So go to that website I showed you last week. Read all about the exam, the kind of questions you may meet. That is also part of your preparation. And yes, we are here at MedCognito. We want to be a part of your success story. So where do you need help with? Do you need any of our crash courses to sort out some confusion in some particular topics? Or you need a full workout for NCLEX? We are here for you.